welcome to another Piper Pod. Today the audio was recorded in front of unit training, so it sounds a little bit different, but this will start a system-based approach to looking at pathophysiology. I hope you enjoy.
The focus of today is going to be looking at the structural side of the house, so we won't be tapping into arrhythmias or anything like that. I'll be looking at the structural changes in the pathophysiology to mostly the muscle structures of the heart and the vessels as we go through more of an introductory to pathophys, just as an overview of what's going to happen. Now, if you're struggling with anatomy physiology of the cardiovascular system, then you're better off going back, reviewing that before moving on to this presentation, because otherwise we're not going to spend too much time talking about the actual anatomy or physiology of it, because we won't have the time. So if you look at the key concepts of what we're going to talk about, this is just a little bit of terminology and things to get your head around before we move on to the essence that is pathophysiology of the cardiovascular system. We have words like ischemia versus ischemic. Now, ischemia just refers to the reduction in oxygenated blood to the tissue. That's it. When you have an ischemic disorder or an ischemic heart disease, it usually means a pathological change in a reduction, so a decrease in that supply of oxygen to that body part. So ischemia and ischemic has both got to do with hypoxic state and the lack of perfusion to an actual tissue area. When we use the word thrombus, we're talking about a blood clot that is actually connected to the side of the vessel. Okay, so when it is no longer connected, it's no longer called a thrombus, it moves on to be called an embolus or an emboli. And as it's connected, it is just a blood clot that's connected to the vessel. Now, there's a few states that encourage a clot to be formed within the body, and they're what's known as the Vicale's triad. And the first thing, the most important state that is needed in order to create a clot is you need an endothelial injury. And what that means is an injury to the internal linings of a structure. Okay, so if you remember back to the clotting cascade, we have both extrinsic and intrinsic factors. Well, the intrinsic factors are all about a destruction starting in the endothelial layers and that releasing a bunch of cytokines and a bunch of vasodilatory responses calling platelets to the area. So any injury to an endothelial area is going to start the clotting process. If we have a reduction in blood flow, so blood becomes stagnant, blood sits in an area, then we can work on a lot more of inbuilt clotting factors. So the clotting proteins that are already within the body can just react themselves because they have the time in stasis in order to do so. And the last one is if you have a state usually caused by genetics or drugs that makes you hypercoagulopathic. Okay, so anything that, like the pill is a classic one. Okay, the oral contraceptive pill is a classic drug that can increase the amount of clotting ability that you have. Okay, so they're the three variables that are at play, and they're called Vicale's triad. The reason I draw so much attention to those is pretty much every disorder that we talk about will have an element of one of those factors causing a clot to form. Now, an embolus we spoke about is when the foreign body is broken up, so we can have an air embolus, we can have a thromboembolus, and we can just have a fat embolus or anything else in the body that's not supposed to be there. It's floating around and it's going to cause a blockage in some form of vessel. And the last one is our infarction. So infarction actually refers to cell death as a result of ischemia. So when you're ischemic, it means that you have a reduction in oxygen. Once that gets too long or too prolonged, you become infarct, and that area is no longer viable. Right, first contributing factor. So hypertension obviously is a state of high blood pressure. Now, if we revert back to what blood pressure is, it's a combination of peripheral resistance versus cardiac output. So the more cardiac output you have, the more volume is being released, therefore the more pressure is going to be available in the actual arterial walls of the circulatory system. Same too as if you have an increase in resistance, you're going to have an increase in pressure. Sort of a way of saying, instead of having a same amount of water or the exact same way down a tube that's a centimetre in diameter. If you did the same thing, a millimetre in diameter, the output and pressure is going to be a lot more. So that's what peripheral resistance really talks about. Now, as far as a diagnosis, it's pretty hard to diagnose because blood pressure is so varied. There's a lot of situations that can increase the blood pressure even non-pathogenically, which like your white coat fever, things like that. So if you get a one-off blood pressure that's too high, you don't really count that as an absolute state of hypertension at all. And there really isn't any blood pressure out there, even in the emergency world, that if you see a number that you're going to be worried about without other contributing symptoms. Now, even if they rock up at 220 systolic, you're not going to be immediately over the moon worried about that without any other signs with it. Now, in order to diagnose someone with prolonged hypertension, the minimal guide is to have two separate blood pressures where the average of those two, systolic or diastolics, is over 140 or 90 systolic. That's the actual minimum criteria. Most of the times you get put away and you get like 24-hour blood pressure monitoring and they get a trend from there. So it's not something that's done easily. On top of that, most of the causes for hypertension are actually unknown. So they're what's called primary hypertension. So things like catecholamine response, cortisol, amygdala response, basically means someone who's always stressed or angry, that sort of thing is going to bring on hypertension, and that is your part of your primary. The other part of the primary is obviously your fat metabolism, obesity, exercise, lack of exercise, stagnant living, those sort of things. So they're all, can't really pin down exactly what the cause is, so they're called primary hypertension. The secondary hypertensions are the ones that are result of some form of other pathological response. So renal, neurological, endocrine, or they're on a medication that causes a hypertensive state. And they only contribute less than 10% of the actual hypertensions that we have. Right, so when we have hypertension, the reason it's a problem. So every time you exercise, you go out working out, you're going for a run, you are going to have a state that your blood sugar is increased. That is normal and your body's willing to respond to it. But just like exercise, you can't do high intensity exercise for a long period of time because of the strain it puts on your body. And you start working anaerobically, asking more of your muscles, no time to repair, regenerate or recover. That's the same as if we have prolonged hypertension. Now, one of the complications and the main one that contributes to cardiovascular pathophysiology is atherosclerosis. So atherosclerosis is a complication of hypertensive state. Now, I'm not going to talk too much about atherosclerosis because we're going to move into it when we start looking at the vessels. Okay, but simply put, it increases the resistance further, which just goes on to increasing the blood pressure, and it also has a reduction in the blood flow. So encouraging clots to form is actually what it does. On top of that, we have hypertrophy. The heart is forced to work a lot harder. We have kidney failure because a lot of these atherosclerotic plaques will fall off and they'll get lodged in smaller areas like the kidney, the brain, or the eye as well. And so from that, just from having high blood pressure, you can have all these complications. And it's actually what they're starting to link people that don't have control over their anger responses. This is actually what causes them to die younger, is a chronic state of hypertension. So that's what they're starting to link. A lot of studies out there proving that. Now, as far as treatment goes, we're looking simple diet, lifestyle, changing that. Smoking obviously is a massive contributing factor to it, as well as fatty food, not exercising, sedentary lifestyle, that sort of thing. On top of that, if it can't be controlled, and especially one of those secondary ones, we tend to move towards antihypertensive medications. But these days we just throw that out without even thinking about lifestyle changes or anything like that. So it can be counterproductive just to get on antihypertensive because you're not fixing the underlying cause with it. So a bit of a holistic approach to hypertension is always a better way to go. Alright, so as mentioned, hypertension moves on to your arterial degrees. So atherosclerosis is one of them. But the first one we're going to talk about is arterial sclerosis. So this one here is a little bit different, and it's usually a disorder of the elderly. So the elderly have a reduction in the elasticity of their arteries, and they also get a pathological hardening of their arteries, but without the plaque and without the growth factors as well. So that is arteriosclerosis itself. And it happens over time because calcium itself sits into the muscle layers of the arteries and therefore just thicken it, basically allow it not to relax from contraction. As long as you've got calcium within the muscles, it's going to hold on to the bonds and you're never going to go through that relaxation state. So that's what causes it to harden in place. And as a result of that, you get a hardening, the arteries can't pump and massage the blood further, so you get a reduction in blood flow, which causes a lot of other problems, obviously. But the main one in the pathological state is atherosclerosis. This is where we actually get deposits of fatty material moving into the wall of the arteries, and they will form fibrous tissue. So they'll actually grow inside the artery, and they'll cause a reduction by a fibrous mass on the inside. Now, on top of that, obviously this is where our plaques come from. This is where plaques can break off in order to cause more problems down the line. And atherosclerosis only affects the medium to large arteries because it has to have the room in the muscle layer and tunica media in order to form this fibrous mass. So any smaller arterioles, they don't have this large muscle layer, therefore they won't actually have that pathological state. If ever you have a peripheral vascular disease or ischemic heart disease, it absolutely has an underlying factor of atherosclerosis. Okay, now atherosclerosis, just for curiosity, is a form of arteriosclerosis. Okay, it's just a very specific type 1. Right, from there, the risk you have, there's shit you can't change. Okay, there's you, your age, your gender, and your hereditary. So if you've got hereditary predispositions for atherosclerosis, then there's not much you can do. Diet, exercise, doesn't really change much, unfortunately. Okay, but if you have a hereditary condition and you add lipid metabolism problems to it, so that means you either constantly give your body sugars or constantly give your body energy, therefore you never burn the fats, therefore you store it, your body doesn't get used to breaking down fats, it ends up forming into cholesterol because that's what a percentage of it will do, and it will move around the body and it will stick to the walls of the endothelial destructions, causing the starting point of this plaque. Okay? Smoking obviously increases that, okay? It increases the actual adhesiveness to it. Have you ever wondered how that happens? Because smoking, the chemicals you put into your bloodstream, will actually destroy the endothelial layers, making a surface for this attachment for the lipids and platelets and things like that. That's what causes it. And hypertension, again, so much pressure running down the vessels will destroy the endothelial layers, starting the whole process. So they're things that you can change about your lifestyle, and to change it, we quit smoking, reduce the amount of fat intake and increase activity in order to have healthy lipid metabolism. And for females that are going through menopause, it can be an idea to take estrogen supplements, because as soon as you go into a hyperestrogenic state, your body goes under stress and you're more likely to form clots as well. Okay. Right, looking at the pathogenesis, how this works. The reason we're moving into a little bit further into this is because this will help your understanding of the actual heart disorders as well. So as mentioned, the damage to the endothelial start with different states, whether it's hypertension, whether it's toxins, or whether it's just any form of stress causing those endothelial layers to get destroyed, which increases the amount of low density lipid adhesion to the endothelial. Okay, so normally the LDLs can move down, no problems at all, go to the areas that's needed, store it into the muscle, store it into the liver, or into the cells themselves to be used later on. In the event that there's endothelial damage, you get collagen fibres that will stick out into the bloodstream, and therefore they will collect the LDL, and all of a sudden you'll have a fatty deposit. Okay, now coupled with that, it also, the collagen attracts platelets, so you end up getting platelet adhesion, and then you have a platelet derivative growth factor that is released as a result of it, and that is what helps form your fibrogen mess in order to create a clot. But now this is happening in the absence of a bleed. It is just because one layer of the endothelium is broken, the processes are going through, so you end up with this big fibrous mess in the middle of your vessels getting formed. And that's actually what happens. From there, that encourages proliferation. It encourages proliferation of underlying structures. So the vessels on the inside of the actual arterial wall increase in mass because they have an infiltration of foam cells and monocytes themselves. So foam cells are basically a space filler. That's why they're called foam cells. They bring into an area in order to allow structural growth. That's what they do. Okay, so that's what foam cells are all about. As a result of that, you end up with a plug on top of the inside of the vessel and then an increased mass underneath it, which obviously reduces the amount of space that is available on the inside of the vessel. Okay, so that is the pathogenesis of your actual atherosclerosis. So as you can see from a picture formation, makes it a little bit easier to understand what we spoke about. When we're on the blue side, we're looking at a pre-clinical phase. So this is the area where there's no signs or symptoms, and this can happen in people's lives up to the age of 10. So in the first decade of someone's life, they can already get fatty streaks forming in their arteries. So depending on lifestyles, that sort of thing, this can already start occurring pretty much from day one. So it's pretty scary stuff. But as it advances, then we start to get that fibrotic fatty formation. As you can see on the inside next to the muscle, we're starting to get that foam cell fibrous mass forming, which is decreasing the availability of the actual lumen. Once it starts getting to the advanced stage, then it becomes vulnerable. And what it becomes vulnerable for is a series of different problems that can occur from there. And so once we get to the advanced side of the house, we obviously have a massive reduction in blood flow that's available, and you have a huge risk of plaque formation falling off as well. So from there, part of the clinical complications can occur is you can have aneurysms. Aneurysms or ruptures of the actual vessels because you are going from a low pressure, hitting this plaque, therefore magnitude increase in the hydrostatic pressure within that area of the plaque, which can cause the size of the wall to weaken and then eventually rupture, bleeding into the external environment. So it's not a good thing. From there, you can also have, again, endothelial destruction on top of the plaque. So it'll start to form a clot, but now you've got no room for that clot to actually not cause a problem. So it completely blocks it off, and therefore you get a occlusion by the thrombus that is formed as a result. And from there you have more of a chronic state of stenosis. And stenosis is basically just a term that means a reduction in blood flow that's available to the other end. Right, so when we start looking at acute coronary syndrome or things like that, or ischemic heart disease, your stenosis plays a massive role in that sort of pathological effects. Okay, so that is one side of the house of what happens within the arteries that causes a problem. The other kind is just your aneurysm. So this is more of an introduction to what happens, but over what sort of number of different pathological states will cause the inside of your arteries to weaken. Okay, so it will cause the inside to weaken down as a result of hypertension, atherosclerosis, even getting hit with trauma, so constant blunt force trauma, that sort of thing weakens the inside of it. You get special sorts of infection like syphilis, or anything like that will really degrade the inside of the arterial walls, and then you have congenital factors. Now the main congenital factor to worry about is a condition called Berry's aneurysm, and this is where you'll actually get pre-formed weakenings within the subarachnoid layers of your brain. Now they're usually completely asymptomatic, but in the event that contact sports or anything like that are played, it makes it very easy to have a subarachnoid rupture and therefore go into the problems of subarachnoid bleeds. Now the different types of aneurysms you can get is you can just move them down from the top, is normal blood vessel, then we have a pseudoaneurysm. This is where you'll have a polyp that grows out from the inside. It's sort of the inside of the vessel finding an area of weakness and then growing out. So still encapsulated, but that obviously opens up to a lot of stagnant blood and a huge risk of clot formation in that area. You have your saccular aneurysm, that's when one side bulges out. They're usually not too bad, slow reduction in blood flow. Most people don't realise that they actually have these sort of ones. Okay? They just will go on living, nothing happens, get to an autopsy and you're like, Jesus Christ, look at that aneurysm, it's enormous. Okay? So it's not always met with actual symptoms themselves, just so you know. Next one is what's known as a fusiform aneurysm. Anything fusiform in anatomy or physiology is essentially where you have a belly on both sides of the formation. That's what a fusiform means. So that is just further reduction in blood flow. And the last one is your dissecting aneurysm. Okay, so classically known as your aortic dissociation. You may have heard of that one, where the descending aorta will actually break apart and part of the blood will start pooling into the descending aorta, just waiting for it. Okay? Now, the most common place for aneurysms to occur is actually the abdominal aorta itself. This is the most common place for aneurysms because it's a large enough vessel to house the aneurysm, and it's enough for clinically to be able to find them as well. Okay, so that's where they're mostly found. So let's move on to the heart itself. So drawing back to atherosclerosis, because it is the leading cause of ischemic heart disease, we'll start talking about the progression of ischemic heart disease really. So when we say that, we've already talked about the terminology, so it's pretty easy to understand what it is. Ischemic heart disease is a reduction in blood flow to the actual heart tissue. That's what it is. So when you have ischemic heart disease, you essentially have a need. Your heart always has a need for a significant amount of blood flow, but now you have a reduction in the amount that can actually get to it. Leading cause, atherosclerosis, but you can also have thrombus formation or emboli moving in, and then you can also have a spasm of the coronary arteries that just reduce the actual size of what the blood can actually get into it. So when we look at clinical manifestation, as we mentioned, plaque and atherosclerosis can form up, and most of the time you'll have it on the coronary walls. And if it's small state, you'll be completely asymptomatic. Now, as that continues, so as we move along and we get a little bit more reduction, we start to move from asymptomatic into angina pectoris. Okay, so when we look at angina pectoris, we either have the two classes. We have the stable, which is generally brought on by exercise. You stop exercising, you reduce the need for the myocardium, and the pain goes away. You maybe take GTN, and then you're good. And then you have the unstable one that comes on all of a sudden at rest. The heart is screaming for more blood, and you can't really give it more. That's the one that we fix in acute coronary syndrome. That's the link that you have. Now, from there, as we move in there, and we have a larger thrombus or a larger atherosclerosis formation, then we have a reduction, further reduction in blood flow. And then we start to move from angina into congestive heart failure. We're not going to talk too much about congestive heart failure because ischemic heart disease is not the only cause of congestive heart failure. It's just a pathological state. From there, as we go down further, we move into myocardial infarction. So as we see, the less blood we have over a period of time or complete reduction in blood, we move from chest pain, angina, just saying that we need more, sort of like your muscles screaming with lactic acid, you need more blood. Moving into a more chronic state of congestive heart failure. Long term, you're asking your heart to do a lot more with what it has, and then you can move into myocardial infarct, which is obviously where the cells of the myocardium start to die themselves because of the complete loss of blood flow. So when we move into myocardial infarction, we obviously always associate that with cardiac arrest, and that's death. But that is not the case. You can have a myocardial infarction, which means a portion of the heart will die, but it doesn't actually result in cardiac arrest or anything like that. Okay, so it can be more controlled. But the other complications besides that is we have impaired contractility. So we have a part of the heart that no longer can contract with the rest of it. The signals can no longer be passed through it. Those myocytes can't pass on any messages, and they also have lost their contractility. Therefore, that portion of the heart isn't contracting as well. As a result of that, you can get thrombus forming in the actual ventricles. If you imagine part of your ventricle wall that is no longer contracting, therefore you have a pocket within that ventricle that has stagnant blood. Therefore, mixed with endothelial destruction from the cell death, you'll have a formation of forming a clot, breaks off into an emboli causing a stroke. Okay, so massive risk. Obvious one is a reduction in cardiac output leading to cardiogenic shock itself. From there we can also, because of the tissue necrosis, you can have a capillary muscle infarction which can affect your actual valve. So you can have valve deformation because of the muscles holding onto it, the chordae tendineae or the papillary muscles that actually hold the mitral, hold the valves in place, can be destroyed, and therefore You'll have bowel disorders, regurgitation, stenosis, things like that. Okay? And part of the heart can actually rupture. The weakness in the side of the wall can be so weak that the pressure coming into the heart can actually cause it to rupture. And this is where you could get an internally caused cardiac tamponade. So blood that is coming into the heart will then leak out into the pericardial sac and will cause a cardiac tamponade as a result. Obviously, arrhythmias can occur, and then because of the cellular death and the loss of smooth movement between the actual heart and the external walls, you can end up with pericarditis as well, because part of the pericardium is now destroyed, not functioning, so you'll end up with a rubbing, inflammatory state of pericarditis. So that is the associated risks, besides death, of myocardial infarction. Looking at that from a statistical point of view, okay, so 20% of people that have a myocardial infarct die within the first day. Okay, that's generally speaking, 20% death. For those that survive, as you can see, as you move on the first week, first year, 10 years, your mobility rate is still pretty high. So your mortality rate is still pretty high. So the first complications that happen in the week is we have arrhythmia formation until they can be stabilised. On top of that, we have other conditions associated with lack of perfusion, and we have further deaths. Within the first year, you'll have another 20% of those people that have myocardial infarct not make it, end up dying, and they'll have further later complications of congestive heart failure. So the heart's been asked to work a lot harder, causing hypertrophy, things like that. So congestive heart failure kicks in, increasing someone's chances of dying. Still have arrhythmias, and then you'll start moving into your risks of ruptures and risks of thrombus formation. By the 10-year mark, most of the people that have a myocardial infarct will die as a result of it. So within 10 years, most of the people that have any infarct will end up dead. In the late complications, again, we're looking more towards your valve deformations and your congestive heart failure as well. Okay, so that's the end results of myocardial infarcts. So you can avoid them at all costs. It's always advisable when you think about it. Right. From there, let's move into congestive heart failure. So as I mentioned, ischemic heart disease can be a contributing factor to it, but this is where, for whatever reason, we have a reduction in the cardiac output from the heart. And now this results in an overall state of lack of perfusion. So obviously, a disease in the pump failure can be one of the causes. A diseases like ischemic heart disease is one of the contributing factors to congestive heart failures. But you can also just have arrhythmias. So electroconductive problems, that means the heart is no longer contracting at optimal rates, the atrium aren't filling the last 30%, you get a reduction in cardiac output, long-term congestive heart failure. On top of that, we have a mixture of increasing someone's afterload or increasing someone's preload that can cause the same sort of problems. Right, yeah, so let's talk about preload and afterload. Who has a pretty good idea of what that is? Anyone? Pretty good idea? What do you reckon? If you don't, that's fine. It's a little bit confusing. So preload is nice and simple a lot of the time. Preload is the amount of pressure coming in to the ventricles or coming into the atrium. Okay, so when we talk about preload, we usually associate it with what's coming in from the vena cava, filling the atrium and therefore filling the ventricles. So when we talk about from a heart perspective, we're talking about the amount of pressure that's exuded onto the ventricles from coming in, resulting in how much force is needed to push it out. When we talk about afterload, we're talking about how much pressure is on the external arteries, meaning how much pressure the ventricles have to use in order to push it past that. Okay, so two different causative agents making a similar problem. So the guts of it is rather we're talking about high volumes and high pressure coming into the ventricles, and when it's causing a larger contraction as a result of structural design, we're talking about preload. So if you've ever heard of Frank Starling, he created a concept called the Frank Starling reflex. It essentially says that the more pressure that is exerted onto a ventricle, the greater force that is going to be resulted in, basically. I can't remember the exact wording, obviously. But what that means is as blood comes in to the right side, it makes it easier to understand, as it fills the ventricle, it causes the myocytes to stretch. And as the myocytes stretch to an optimal range, you actually start lining up your actin and myosin more perfectly. So at rest, the actin and myosin of the cardiac muscle is actually not optimally placed. So if you were to contract under those conditions, so low preload, it's a very weak and half-assed contraction. And the more blood you put into it, the more stretch you have to capacity based on the fibrous pericardium, and you'll get to an optimal state. Now sometimes this optimal state can be fantastic, like when we need to run, when we need to do exercise, we need more blood to come out. But if that is happening as a result of increased preload at rest 24 hours a day, then that is going to cause a big problem on that side of the heart, because you're going to start fatiguing it. And when you fatigue it, you're forcing it to adapt and therefore grow or change in some way. Now, the afterload is a little bit different, as the afterload is talking about the amount of pressure that is found in the vessels, the arteries on the other side. So if you think about the aorta, if you have a very high amount of pressure in the aorta, then the ventricle is going to have to create greater pressure than the aortic pressure in order to push the blood out. So if you have a blood pressure of 120, okay, at the brachial artery, it will probably mean you'll have a pressure of about 140 at the aorta. Okay? So it's not that much different. Which means your heart only has to exude more than 140 millimeters of mercury to push the blood out. If you have a resting blood pressure hypertensive state of 160, then you're going to have 180 around at the heart, which means your blood pressure that's exuded from your ventricle is going to have to be greater than 180 24 hours a day. Obviously, you're going to put a lot of strain on the heart, and that's what's going to cause your congestive heart failure. So when we look at the different side effects, meaning the opposite sides of the heart and what the problems is that we have as a result of it. So the left heart, we have to think about what comes before that side of the heart. A lot of the times when people talk about left side of the heart or right side of the heart, you think about what it's feeding, and you usually associate that with the problem. But you've got to think about what comes before it gets to that side of the heart. So looking at the left side of the heart that feeds the body, it gets its blood from the pulmonary circulation. So if we have an increase in pressure within the left atrium as a result of left side of heart failure, it's pumping really weak, the ventricles are filling up, not releasing as much as it can, so you have an increase in pressure on that left side, which transmits that pressure to the pulmonary circulation. The pulmonary circulation has an increase in hydrostatic pressure, which results in a huge amount of fluid leaking into the lungs. So as a result, we get dyspnea, fluid in the lungs. Obviously it stops the gaseous exchange because you have a much greater medium to try to pass the oxygen across, and it can't do it. So you have dyspnea, you have hemoptysis, because the capillary structures around the alveoli become so engorged with fluid that they actually rupture, and then you have cyanosis because of an overall reduction in oxygen that's getting to the body. Okay, so pure hypoxic state. That's left side. When you look at the right side of the heart, that's getting filled from the vena cava. Okay, so you have a backup in the right atrium, therefore you have a huge amount of pressure that is being passed on to the vena cava. Now normally speaking, the vena cava's blood pressure is 0. When it comes into the heart, it's actually at 0. Okay? So as soon as it reaches into the right atrium, we're looking at a net blood pressure. So if you have an increase from the atrium, that transmits it onto the vena cava, and now all of a sudden you have pressure within the vena cava that transmits it down to the entire venous circulation. And then thanks to gravity, or thanks to anything pooling of areas, we obviously get problems associated with that. So we have distended neck veins, because the inferior vena cava that is draining from the head gets a backload, and our jugular veins end up distending. We also get hepatomegalia, because the venous feeds a huge amount of the portal hepatic circulation, so we get a backfill in there, causing the liver to engorge in space, okay, and therefore become less functional. And obviously the old classic is you get pitting edema, leg swelling as a result. That's what most people associate with right side of heart failure, is just a really large swelling of the legs. Okay, usually associated. We see it a lot with pregnancy as well for similar events. Okay, so that is your classic congestive heart failure that occurs. We're just going to finish up with a few other interesting pathological states associated with the heart, just to keep in the back of your mind, more for interest sake. We won't spend too long on them. But the first one is rheumatic heart disease. So anything rheumatic is structurally very, very interesting, okay, because it's a result of a natural defense system that is supposed to help you having a cross-linked reaction with the rest of your body, causing profound inflammation. Okay, so it's very, very unique in nature, and it starts with the Staphylococcus A beta hemolytic bacteria. Okay, so once you get a strep A or staph A infection, usually of the throat, you have a 1 in 1,000 chance of having a rheumatic attack to some extent. So this bacteria, obviously, as bacteria do, will end up being picked up and then taken to your lymph nodes. It'll end up in your lymph and it'll move through into your lymph nodes, and in your lymph nodes, your B lymphocytes, okay, your cell-mediated immune response will kick in and it will produce antibodies, like it does. Okay? It will produce antibodies. Antibodies will flood the system. Now the problem with these specific antibodies is they can link to different areas of your body and bind to the sites of your body and actually start that inflammatory process in the absence of any cellular destruction at all. So obviously inflammation usually has to have some form of cellular destruction. These antibodies will bypass that by binding to those sites, starting an inflammatory response. So when it goes to the heart, we end up with acute rheumatic heart disease. Now the problem with it is, obviously, is it can affect any part of the heart. So you can have inflammation on the inside, which is endocarditis, usually associated with the valves. You can have myocarditis, which mimics hypertrophy itself. And then you can also have pericarditis of any of the layers. Rheumatic heart disease, can even cause pancarditis, which is the inflammation of your entire pericardial layers, all three of them. So it's a very unique source. So it's like having bacteria infiltrating those particular areas, but in the absence of it, it's just a semi-state of a special autoimmune response is actually what causes it. And as a result, you have the side effects associated with vegetation, hypertrophy, or pericarditis itself. Right, the next one is, of course, our bacterial endocarditis. So this is looking at, similar to what you'd get with rheumatic heart disease. The difference is this can go on causing a lot of other problems without the associated inflammation from the original one. So what happens is it always starts with some form of mitral, or just valve defect. Some form of valve defect that causes the endothelial layers to open, therefore starting plaque and starting fatty and fibrous formation on top of the valves. Now the interesting thing about it is it can actually also happen for artificial valves. So artificial valves can either pick up blood supply, therefore be used as ours, like pig valves, things like that, or they can be completely artificial, but then have the starting of proliferation growing over the top, which will release the same sort of cellular mediators as if they were destroyed. It doesn't matter if it's artificial or not. It starts with your platelets and fibrin formation, and then bacteria move in. Once bacteria moves into it, it causes vegetation. So vegetation will start, and then you'll start to get enlarging and fibrous formation of that area, because that's a healing process. It becomes scar tissue or some sort of fibrous formation. As a result of that, a few different things happen. So we have vegetation within the valve, so we either have shortening of the chordae tendineae, and what that does is it causes the valves to actually be contracted and pulled down further, which creates a hole in the valves themselves. Also, you can actually get pure inflammation of the valves themselves, which means that now when they're open, they're not as open as they used to be. So the complications from bacterial endocarditis are initially stenosis, so a reduction in the amount of blood that can actually come in. You can also get regurgitation, that is where you don't have a complete closing, so blood from the left ventricle will actually move back into the atrium, things like that, it's regurgitation. And then from there, these plaque formations, these infectious plaque formations, can actually break off and then move all over the body. So you can end up with, and it's quite common to see, skin infarcts or abscesses forming all over the skin, usually the hand. You get little polyps looking like a systemic staph infection just moving throughout your body. You can get anything associated with clots of an emboli can also occur. So you get your gangrene, renal, brain, stroke, a skin and heart disease, anything like that can occur because the emboli break off, go into smaller vessels, and then cause problems. The infectious particle can move into the bones, causing a weakening, osteomyelitis, and essentially this infectious plaque, anything that a plaque can cause or an infectious state can cause, can be a secondary effect of bacterial endocarditis itself. So it's a pretty nasty one to look out for. Alright, generally, cardiomyopathies. Now these are a little bit difficult to get your head around because the main thing you need to remember about cardiomyopathies is it excludes that pathological state as a result of a cardiovascular disease. So in the event that you have congestive heart failure, you have ischemic heart disease, you are going to get similar structural formation defects of the heart. This, when you talk about cardiomyopathies, you're talking about that infectious state or that pathological state occurring in the absence of any one of those disorders. So there are hundreds and hundreds of genetic-based disorders that causes adaptation of the heart, which is known under the umbrella of cardiomyopathies. So the main thing is there's a structural change to the heart that results in a reduction in ability and therefore a reduction in cardiac output. So you can either get dilation, that's where the heart will just get floppy, it's formed, won't be there, its fibrous pericardium won't be as strong, so it will open up and bulb out. And that opens up for more stagnant pockets, which creates thrombosis, and then obviously they can break off and cause emboli. You can get hypertrophy, so just largening of the heart, reducing the amount of space within the actual ventricles, therefore overall reduction in cardiac output and need for more work. And the last one is restrictive. Now restrictive is difficult to get your head around, and it's very, very rare. So this is where you'll often get perfect contraction, perfect electrophysiology, but as it relaxes, that's where the problem lies. So it actually has a problem in its recoil function. So it will contract beautifully, but then as it goes to relax, it'll be slow, sluggish, difficult, therefore needing a lot of pressure coming into it in order to fill it to its optimal state. So it usually results in the body adapting with an increase within preload, so actually keeping a lot more fluid than it should to compensate for this cardiomyopathy. Okay, and then we have good old pericarditis. Like most regions of the body that have outer layers, the pericardium is designed, one, in order to fix the heart within a certain space. So it doesn't matter how much you fill it, it's not going to fill to the point that it's going to rupture. Okay, and not without having some form of infarct or death to the muscle itself. So that's what the fibrous pericardium is all about. The two internal pericardiums, okay, the visceral and the parietal pericardium, they're layered with fluid, just like your pleural space. And they're designed to allow a huge amount of movement with one another, creating a massive vacuum or a surface tension to move without creating the cellular structures to touch and therefore be destroyed. So obviously if any of the cellular structures get destroyed, they're going to start inflammatory response. That's what happens. So by having this layer within the pericardium, this fluid, it protects it, lubricates it from damage, which means it can move, it can contract without causing a problem. When it becomes a problem, so when it gets inflamed, we're looking at those two layers being inflamed, moving that fluid out of the way in an inflammatory state. Now that causes the two areas to touch, and therefore it prolongs and has a profound effect on further inflammation. So it generally will affect eventually the entire pericardial layer, because the inflammatory mediators can travel in the fluid surrounding the heart, therefore affecting the whole region. So when you have pericarditis, you can actually have the whole heart is generally affected. You'll see it on an ECG as an entire heart affected by pericarditis itself. Now that inflammation causes a reduction in the space available within the heart, which causes a reduction in cardiac output. It also opens it up through vessels to rupture, making it a lot easier for vessels to rupture, which causes a cardiac tamponade as well. Now when we get pericardial effusion, that is where we get a link, usually associated with the vessels surrounding it, that causes increased permeability to those vessels. And more fluid will leak into the pericardial space, and you'll end up with a tamponade not caused by blood. It's a tamponade of pericardial fluid itself. That's what pericardial effusion is. Okay, that is cardiovascular pathophysiology in a nutshell.
I hope you got something out of it. Until next time, take care.